So what is DELIVER? So DELIVER is really the final piece of the jigsaw in terms of the large randomized trials in ambulant patients with heart failure. It's the fourth of the big trials, and this is where it fits in. It's basically the sister trial to DAPA-HF. So there are two trials with empagliflozin covering the spectrum of ejection fraction. There are two trials with dapagliflozin. DELIVER was a dapagliflozin placebo comparison in just over 6,000 patients with an ejection fraction above 40%. So you can see the other entry criteria here. Basically, patients had to have symptomatic heart failure. They had to have a modest elevation in natriuretic peptides, and they had to have evidence of structural heart disease, either left atrial enlargement or left ventricular hypertrophy. They were randomized to a single dose of dapagliflozin, 10 milligrams once daily, or placebo, and this was an event-driven trial with the primary composite endpoint of a worsening heart failure event or cardiovascular mortality. So the patients were aged 72 years of age, and on average, 44% of them were women, about 45% had diabetes, nearly 90% had hypertension, very typical of trials in this type of heart failure. So this is the primary composite endpoint, and worsening heart failure here means either admission to hospital with worsening heart failure or worsening heart failure requiring intravenous therapy, but not an admission to a hospital ward. Most of these events were actually heart failure hospitalization. So you can see there was a significant reduction in the primary composite endpoint. The relative risk reduction was 18%. The absolute risk reduction was fairly large. The resulting number needs to treat was small at 32, and that's over a median follow-up of 2.3 years. Now, what's important is that this is the second trial with an agent in this class in patients with an ejection fraction over 40%. And I put the DELIVER trial side by side here with Emperor Preserved. This time I'm showing you not the DELIVER primary endpoint, but the Emperor Preserved primary endpoint. And I'm doing this so that you can compare these two trials directly. You'll see the same endpoint, same y-axis scale, and what you can see is the really consistent benefit here in patients with heart failure and an ejection fraction above 40%, around a 20% reduction in this sort of standard composite endpoint. Now, rather than tell you more about all the sort of secondary endpoints and so on, DELIVER, I thought I'd give you an update on some of the more interesting things that we've presented and published recently. Now, we've presented and published a lot. There are about 20 papers already there for you to read if you want. But I think a couple of them that are important are the meta-analysis that we published in the Lancet. This particular figure focuses on improvement in patient-reported outcomes using the Kansas City Cardiomyopathy Questionnaire. What you can see in the upper part of this figure is that there were a higher proportion of patients having a 5, 10, or 15-point improvement in their KCCQ score, so improvement in symptoms, improvement in quality of life. A 15-point improvement is really unprecedented for drugs and device therapy in heart failure. At the bottom, you can see that patients were significantly less likely to report worsening of their symptoms or quality of life. Now, if you don't like patient self-reports, here is NYHA class assessment made by the investigators, obviously in a blinded way. And what you can see, again, is that NYHA class was more likely to improve in the dapagliflozin group compared to the placebo group, was less likely to deteriorate in the dapagliflozin group, shown in blue, compared to the placebo group, shown in red. But please note that the bars to the far left of the slide, as you look at it, show change at just 4 weeks after randomization, emphasizing how quickly the benefit of these drugs is observed by physicians looking after these patients. Now, another extremely important analysis was to determine whether or not the benefit of these drugs is actually seen across the whole spectrum of ejection fraction, even in people with a completely normal ejection fraction, because we know that the benefits of the other drugs that we use in heart failure, drugs that basically act through neurohumoral systems and digoxin, their benefit is attenuated or indeed is absent when the ejection fraction is within the normal range above 55 to 60%. So it was really important to know whether or not this was also true of SGLT2 inhibitors. So we had a pre-specified analysis pooling the DAPA-HF and the DELIVER trial. So now we're looking at 11,000 patients covering the whole ejection fraction spectrum. The lower 1 percentile is 16%, the upper 99 percentile was 74%, so really the full range of ejection fraction. And what you can see from this figure, the blue line is a continuous hazard ratio. The horizontal black line is a hazard ratio of 1. So if the blue line is below 1, that's indicative of benefit of dapagliflozin. You can see a consistent benefit across the whole range of ejection fraction. There was not that slope that you saw in the continuous hazard ratio line for the other drugs. These treatments work across the whole spectrum of ejection fraction. Another thing I want to point out is how quickly these treatments work. And we've, again, recently reported an analysis where we looked at when that hazard ratio fell below 1 and remained below 1. So you can see to the right of this figure, again, a continuous hazard ratio. The gray shaded area or blue shaded area is the 95% confidence interval. That falls below 1 and remains below 1 from just 13 days after randomization. So these treatments work incredibly quickly, both in terms of improving symptoms and quality of life, but also in reducing events. And then finally, these data were presented just a couple of weeks ago at the American Heart Association. And this is looking at not what we traditionally do in trials, which is what we call first events. So normally when you see trial results presented, it's timed to the first occurrence of something. But of course, we know in heart failure, particularly this type of heart failure, many patients experience repeated events. So they have a heart failure hospitalization, maybe another 1 or 2 heart failure hospitalizations, then they might die. In a traditional analysis, it's only the first heart failure hospitalization that counts in those Kaplan-Meier curves that you're so familiar looking at. This is an analysis that looks at all events, and what you can see here is that clearly dapagliflozin reduces total events, and in fact, the cumulative event curves here are continuing to separate by the end of the trial. So I'm not going to read through this summary conclusions. I think it tells you what, it summarizes what I've already told you. And it's interesting, we've been even wondering back home in the United Kingdom, where at the moment the National Health Service is struggling a bit to recover from the pandemic. Patients are often waiting some time to be formally assessed by a cardiologist to have an echocardiogram. And we've been wondering, given that these treatments are so effective so quickly across the whole spectrum of ejection fraction, whether patients should even be started on this type of treatment while waiting for formal assessment. So with that, I'd like to thank you very much indeed.